Hi, everyone. I'm Andrew, and I'm going to be speaking with you today about, let me get this up on the screen, So health technology management. So a bunch of projects we've been running at Flinders University as part of the NHMRC Partnership Centre in Health System Sustainability. I have put a little pause sign in the top just to remind you that you can stop this video at any time and study the slides. You can speed me up, slow me down, whatever you like. So yeah, health technology management. Look, as health economists, we often get involved in health technology assessment. So, the appraisal of pharmaceuticals, medical devices, sort of simple technologies. But technologies can also include those with more complicated, complex, multiple components. So, the intersection of workforce, built environment, consumables, information communication technologies, so services, essentially. Systems for delivering care as technologies. And look, we spend a lot of time in hospitals and health services doing this kind of thing. So brown paper mapping, looking at dashboards, working with teams of clinicians and administrative stakeholders, where the question in that context is less about, yes or no, should we accept the price at which we could procure something off the shelf that's been developed external to the organization. I mean, those conversations happen, but we're less interested in those questions. We're more interested in questions of adaptation. So rather than adoption off the shelf, more adaptation of the things that we're already doing locally. It's more about essentially an earlier step in the process of developing and designing our own technologies, our own interventions, our own services. So we're involved in that kind of conversation, and in that context, what we're talking about is really then a search for efficiency. The idea being that the value-based healthcare conversation, the health economic conversation, is around not whether or not something is or isn't cost effective, but what would be the conditions under which we might expect what we want to do to be cost effective. And we toggle on and off different options, different parts of a new model of care, a new protocol, a new guideline. And we put those in our business cases. These are the conversations that we're having. So much earlier process in actually developing and designing technologies. And look, we've got a number of different methods to use for this. Of course, we can talk about data linkage, but we always start out with a qualitative step. So this is a logic model, conceptual, causal logic modeling, asking lots of questions, referring back to the published literature and evidence from other settings. To think about, what's being done for whom, with what kind of effect, and why. So understanding what is local current care for different populations and subgroups. What might an intervention look like? What are the different components? How do they interact? What are the mechanisms by which they improve quality of life, length of life, patient experience, costs, funding, other operational metrics like throughput, that kind of thing. What's the context in which it exists? Be it political, economic, socio-technical, those kind of things. What are the exogenous and endogenous factors that go into that causal logic? And that helps us when we're putting together the linked data, the routinely collected linked data, and looking for evidence within the published literature, to then do this kind of thing. So data mining of patient pathways and learning about where are people going in the system, where are they going, what sequence of events occur in their care. How quickly do they get there? What kind of accumulation of resources is required along their journey? But we do move quite quickly then into these decision models, which are much sort of simpler abstractions of this complicated, complex reality. We're talking decision trees, not complicated simulation models. So decision trees that describe existing care, but also set us up to talk about, or to be able to analyze our expectations around, well, what might happen if we were to change things. And where we get the numbers and the parameters of those potential changes is through elicitation. So consulting the evidence, published evidence, looking at local data, using that as part of a structured elicitation framework to get some numbers that we plug back into the decision model, and it updates our understanding of how things work and how we would expect them to work into the future. It updates our conceptual logic model. That's why it's circular. I wanted to give you a quick look at an Excel file. We use Excel because everyone can open it on their computers in the health system. And it's much more transparent than some of the other modeling tools. But we're looking here, say, at 10,000 older adults presenting to an ED in a particular hospital. And we're looking at their pathways through non-admitted care, through admitted care, even if it's just in the ECU, or through to the ward, where they may then subsequently receive GEM or hospital in the home, palliative rehab care, maybe placed on care awaiting placement. And we're profiling their lengths of stay in the ED, in inpatient settings. We're looking at the distribution in those lengths of stay. Also looking at distributions in what we said, the funding gap. So the difference between activity-based funding, block funding revenues coming in and the expenses, the actual expenses in providing care going out, different hospitals for different patient groups, for the same patient groups following different pathways. Sometimes it's quite different, and we see that, we see those averages and those distributions. Of course, we're also talking about the outcomes, the patient relevant outcomes. In this case, the linked data that we've got is readmissions, representations, mortality, but it could, depending on your linked data, if you've got outcomes and prems and things like that, can all form part of the same picture. So looking at different pathways and describing some of those key performance attributes that we then use to look at with services to say, this is what's currently happening. So at a high level, this is just an abstraction of that file we were just looking at. Essentially, we're saying, so for those 10,000 patients, we talk about, are they admitted? Are they not admitted? If they're admitted, where do they go? How long do they spend? What kind of financial implication does it have for the LHN? And what are some of the follow-on health outcomes? Of course, the question in health services that we often come up with is, look, of those patients who would otherwise follow those pathways, if we put together a new model of care, could it be different? Could we improve that? So rather than presenting to the ED in a new model of care, rather than presenting to the ED, could we say head off a proportion of those from the ED? Could we put them through different pathways, through urgent care centres or home visits that lead them on to out of hospital care, or they may have to be stepped up back into the hospital? These are all questions that we asked through an elicitation process, looking at the literature, looking at local data. We also ask lots of questions at the end of each of these pathways. We look at quantities such as length of stay and say, what's the average length of stay in different settings? So lots of questions. We haven't got time. I'm not going to go into the elicitation method specifically today. Just to say that there's a great reference model out there for thinking about how you combat different cognitive biases and ask questions in particular ways so that they're informed and robust and defendable. It's a really good protocol. I'd check it out. This is another example, so different from what we were looking at before, then of how it can all be pulled together and summarized in other tabs of Excel models so that we can compare different options. So this is a cost consequence framework, so multiple disaggregated measures of effectiveness, comparing essentially one proposed configuration of resources, one service model, against a status quo or a base case existing care model. And it's by no means a full suite priority setting approach like PBMA, or it's not intended to be put into league tables. It's just a first step in running a value-based healthcare kind of conversation around the service planning, service management process. But it does get at some of the essential criteria around incremental costs, some marginal gains. It sets us up to have conversations about whether or not the outcomes offset the expenses, the price, and whether that's acceptable for the local health setting. We have some conversations a little bit about the value of a bed day. It's very controversial. Do we want to put numbers on that? These are all economics, value-based health conversations that we're having with the service as part of their planning. But like I said, it's a process. It's an iterative process. So we're really keen to stress this idea of it as being sort of, our models become out of date as soon as we stop looking at them. They have to be living models, living documents, because the context is always changing. There's lots of different projects happening, overlapping all the time. So we run we run conversations essentially off these models, and that's what we've been writing about. And I'm really keen to hear, if you've got your own projects like this or have lots of questions, yeah, please get in touch. We'd love to hear from you. My time is done. I'll see you soon in the questions. And now I'll try and stop the video. Thanks. Bye.